Good morning, students. Today we will have chronic myelogenous leukemia, which is a Philadelphia positive myeloproliferative neoplasm. CML or chronic myeloid leukemia is a myeloproliferative neoplasm characterized by overproduction of myeloid serous cells that continue to differentiate and circulate in the blood. Epidemiology: CML constitutes 20% of all leukemia cases in USA. The median age at presentation is 57 years in Western countries and from 43 to 45 in Middle Eastern and Africa. Etiopathogenesis risk factors: AML is commonly occurs after exposure to benzene or work as radiologist without protection. Also, it could occur from 5 to 12 years after exposure to ionizing radiation. Molecular pathogenesis: it is Philadelphia positive in 100% of patients. Now, diagnosis: we will have clinical manifestations. Symptoms: most common symptom is accidental discovery in 50% of patients. When a patient do CBC, we will discover accidentally a very high white blood cell count. The other important symptom is splenomegaly, which can cause left upper quadrant pain or fullness, or typical dragging pain if it is huge splenomegaly. Thrombocytosis can cause thrombotic symptoms. Patients rarely presented with gouty arthritis, with upper gastrointestinal bleeding. In cases with progression, patient may have bone pains, fever, or arthralgias. Sludging of cells in pulmonary or cerebral vessels resulting in the appearance of leukostatic symptoms as dyspnea, drowsiness, confusion, visual disturbances, and loss of coordination. Signs: in 60% of patients, the most important sign is splenomegaly. In 20% of patients, hepatomegaly could be present. Lymphadenopathy and infiltration of other tissues are uncommon. Acute febrile neutrophilic dermatosis or Sweet syndrome, as in this figure, can occur. Laboratory diagnosis: leukocytosis with neutrophilia and left chest that could extend to blast cells. Basophilia and eosinophilia are also common. Thrombocytosis is common. Anemia in 33% of patients. Blood film is very important to notice granulocyte at all stages of maturation in blood film, as metamyelocytes, myelocytes, promyelocytes, and sometimes myeloblast. Low neutrophil alkaline phosphatase score, which is very important to discriminate CML from leukoid reaction. Increased serum level of vitamin B12, lactate dehydrogenase, and now, if we do a bone marrow aspirate for this patient, the bone marrow will be hypercellular with myeloid hyperplasia. Cytogenetic analyses will show Philadelphia chromosome positivity, which establishes CML diagnosis. PCR able rearrangement quantitatively by PCR in marrow or peripheral blood cells. Differential diagnosis: as we say, we have to differentiate CML from leukoid reaction. As you see, leukoid reaction, which is increased white blood cells as a reaction to an infection. So we will have leukoid reaction. We could have the clinical manifestation of the cause of this reaction. The white blood cells count commonly less than 50,000 per microliter. The granulocytes may show toxic granulation, baculation, or Doppel bodies. Will have absence of basophilia, and the most important is normal or high neutrophil alkaline phosphatase score, while it is low in patients. So, CML has to be differentiated from other myeloproliferative neoplasms and myelodysplastic syndromes, as in patients with polycythemia vera associated with iron deficiency and presented with leukocytosis and thrombocytosis. Also from patients in a prefibrotic stage of primary myelofibrosis with neutrophilia and thrombocytosis. In those, there is normal or high neutrophil alkaline phosphatase score. Cytogenetic analyses are the proof of diagnosis. CML also have to be differentiated from chronic myelomonocytic. Now, clinical course. CML is a three-phase disease. The first phase is chronic phase, and the accelerated phase, and the plastic transformation phase. Now, the WHO characteristics of phases of CML. As regarding chronic phase, the patient is usually clinically stable. It could be asymptomatic or symptomatic, but stable. The peripheral blood or bone marrow blasts are commonly less than 20%, less than 10%. This rarely occurs. Now, accelerated phase. In this phase, the condition of the patient starts to deteriorate with worsening anemia, progressive splenomegaly, unresponsive to treatment, and hepatomegaly, fever, bone pains, malaise, and weight loss. We will have in his CBC increasing white blood cells and or platelets. Platelets could have thrombocytopenia less than 100,000. Peripheral blood or bone marrow blasts could be from 10 to 19%. You see, this is the blast, and the peripheral blood basophase more than 20%. This plastic changes, myelofibrosis, or clonal evolution may be present in bone marrow studies. Absence of complete hematologic response during the first line treatment. Plastic transformation phase, which is the patient will be presented with a clinical picture similar to acute myeloid leukemia or acute lymphoblastic leukemia according to the transformation. So we will see extramedullary plastic CML in nodes, skin, meninges, particularly in lymphoid transformation or other tissues. We will have hematological, cytogenetic or molecular resistance to treatment with another TKI, the presence of more than 2 BCR-able mutations during the TKI therapy. Peripheral blood or bone marrow blast will be more than 20%. 70% of patients usually transform to myeloid, and 20% to lymphoid, and 10% are commonly undifferentiated. Treatment of chronic myeloid leukemia, it will depend on the phase of the disease. So treatment of chronic phase, the first line drug is tyrosine kinase inhibitors. The tyrosine kinase inhibitors imatinib mesylate was discovered in 1999, and it is a specific inhibitor of the fusion protein BCR-ABL and blocks its tyrosine kinase activity through competing with adenosine triphosphate binding, as you see in this figure. Dose is 400 mg per day. That could be tailored according to response, tolerance, and side effects. We should add allopurinol in conjunction with TKI to prevent hyperuricemia and gout. Side effects of imatinib mesylate. The most important, the most common one is myelosuppression. In 5% of patients, there is serious side effects such as skin rash, nausea, vomiting, hepatic, renal, or cardiopulmonary dysfunction, and appearance of chronic. Monitoring of response. We can monitor response to TKI treatment in patients with CML by CBC and physical examination that should be done weekly or every 15 days to ensure absence of leukopenia or thrombocytopenia. Then every 3 months of complete hematologic response achieved. Bone marrow aspirate and cytogenetic analyses after 6 months. Definition of responses to imatinib treatment in patients with CML. Now, imatinib failure or primary resistance is defined as failure to achieve complete hematologic response after 3 months or any significant cytogenetic response after 6 months. Alternative for patients with imatinib failure or resistance, either to increase the dose or to use the more potent second generation cytogenetics or to use the more potent second generation TKIs or tyrosine kinase inhibitors as nilotinib or dasatinib. We may also use cytoreductive drugs as hydroxyurea. We can use alpha interferon and lastly allogeneic stem cell transplant. Now if the patient becomes BCR able negative with PCR, whether to stop imatinib or not is not known till now. Regarding the treatment of accelerated oblastic transformation phase, imatinib could be used. However, resistance develops rapidly. We can try the second generation TKI as we tell before, or we can treat the patient as ALL or AML. Prognosis, we have three prognostic scoring systems: SOCAL, Hasford and IOTIS scoring systems. The most commonly used one and simple one is the IOTIS scoring. Now lastly, this is my references if you need more details about this topic, and good luck to all.